Hello everyone, today I am going to teach you about acute pancreatitis. Generally, pancreatitis is the inflammation of the pancreatic parenchyma. Acute pancreatitis is defined as an acute condition presenting with abdominal pain, a threefold or greater rise in serum levels of pancreatic enzymes amylase, or lipase, or characteristic findings of pancreatic inflammation on contrast-enhanced CT scan. In acute pancreatitis, there is little or no fibrosis of the gland. Acute pancreatitis accounts for 3% of all cases of abdominal pain admitted to hospital. For causes of acute pancreatitis, remember the mnemonic, get smashed, so the causes are gallstones and biliary tract diseases. Alcohol, trauma, toxins, steroids, surgery, mumps, autoimmune diseases, ascaris infection. Snakebite, hypothermia, hypercalcemia, hypertriglyceridemia, ERCP, and drugs. Acute pancreatitis occurs as a consequence of premature intracellular trypsinogen activation releasing proteases that digest the pancreas and surrounding tissue. There is simultaneous activation of nuclear factor kappa B leading to mitochondrial dysfunction, autophagy, and a vigorous inflammatory response. The severity of acute pancreatitis is dependent on the balance between the activity of released proteolytic enzymes and antiproteolytic factors. The latter comprise an intracellular pancreatic trypsin inhibitor protein and circulating beta-2 macroglobulin, alpha-1 antitrypsin, and C1 esterase inhibitors. This slide shows the sequence of events leading to pancreatitis. There is intrapancreatic activation of pancreatic enzymes, secondary to pancreatic ductal outflow obstruction or direct injury to pancreatic eosinophil cells. This leads to enzymatic autodigestion of pancreatic parenchyma. So there is attraction of inflammatory cells, neutrophils, macrophages leading to release of inflammatory cytokines that results in pancreatic inflammation, pancreatitis. Capillary leakage leads to the release of inflammatory cytokines and vascular injury by pancreatic enzymes leading to vasodilation and increased vascular permeability resulting in shift of fluid from intravascular space into the interstitial space leading to hypotension and tachycardia. Distributive shock, pancreatic necrosis occurs because uncorrected hypotension leads to decreased organ perfusion resulting in multi-organ dysfunction, mainly renal, and pancreatic necrosis. Hypocalcemia occurs because lipase breaks down peripancreatic and mesenteric fat, resulting in release of free fatty acids that bind calcium leading to hypocalcemia. This flow chart shows the pathogenesis of acute pancreatitis. The signs and symptoms of acute pancreatitis are severe upper abdominal pain, which radiates towards back. Nausea, vomiting, tachypnea, tachycardia. Bowel sounds may become quiet or absent as paralytic ileus develops. In severe cases, the patient becomes hypoxic and develops hypovolemic shock with oliguria. Discoloration of the flanks called Gray-Turner sign, or the periumbilical region, Cullen's sign, is a feature of severe pancreatitis with hemorrhage. The laboratory investigations are as follows. Serum amylase is classically raised 3 or more times normal. Hypocalcemia is relatively common. Raised bilirubin and/or serum aminotransferase suggest underlying gallstones. Amylase is efficiently excreted by the kidneys, and concentrations may have returned to normal if measured 24 to 48 hours after the onset of pancreatitis. A persistently elevated serum amylase concentration suggests pseudocyst formation. Serum amylase concentrations are also elevated, but less so, in intestinal ischemia, perforated peptic ulcer, and ruptured ovarian cyst. Serum lipase measurements are preferable to amylase, as they have greater diagnostic accuracy for acute pancreatitis. Plain X-rays should be taken to exclude other diagnoses, such as perforation or obstruction. Ultrasound scanning can confirm the diagnosis. The ultrasound scan may show gallstones, biliary obstruction, or pseudocyst formation. Contrast-enhanced CT scan is not routinely used, but it is indicated only when diagnosis is uncertain. In severe acute pancreatitis, to distinguish interstitial from necrotizing pancreatitis. Patients with progressive clinical deterioration. And when local complications are suspected. Acute pancreatitis can be mild or severe. Mild acute pancreatitis is when acute pancreatitis associated with minimal organ dysfunction and has an uneventful recovery. Severe acute pancreatitis is when acute pancreatitis associated with organ failure and/or local complications such as necrosis, abscess, or pseudocyst. The severity of pancreatitis can be assessed by using following criteria. Number 1, Ranson's criteria. Number 2, Apache 2 score. Number 3, Glasgow scale. Number 4, C-reactive protein. Ranson's criteria includes 11 parameters, out of them 5 are measured at admission and 6 after 48 hours of admission to hospital. This criterion is used to calculate the mortality of the patient and thus has prognostic impact. At admission, age greater than 55 years. White blood cell count greater than 16,000. Blood glucose greater than 200 mg per deciliter. Serum lactate dehydrogenase greater than 700, aspartate aminotransferase greater than 250 after 48 hours, hematocrit decrease greater than 10%. Blood urea nitrogen elevation greater than 5. Serum calcium less than 8. Arterial partial pressure of oxygen less than 60. Base deficit greater than 4. Estimated fluid sequestration greater than 6. Similarly, Apache scoring above 8, Glasgow score of 3 or more, and C-reactive protein level greater than 150 and worsening of clinical conditions are the indicators of severe disease. The differential diagnosis of acute pancreatitis includes perforated viscous acute cholecystitis and myocardial infarction. The local complications of acute pancreatitis are acute fluid collection, sterile pancreatic necrosis, acute pseudocyst, pancreatic abscess, pancreatic ascites, pancreatic effusion, portal/splenic vein thrombosis. Pulmonary complications are pneumonia, atelectasis, acute respiratory distress syndrome and pleural effusion. Cardiovascular complications are hypotension, hypovolemia, and pericardial effusion. Hematologic complications include disseminated intravascular coagulopathy. Gastrointestinal complications are peptic ulcer, portal vein or splenic vein thrombosis with varices. Renal complications include oliguria, renal failure, renal artery or vein thrombosis. Metabolic complications includes hyperglycemia, hypocalcemia. Central nervous system complication are psychosis, fat emboli. Fat necrosis causes intra-abdominal saponification and subcutaneous tissue necrosis. In case of mild attack of pancreatitis, conservative approach is indicated and includes intravenous fluid administration, monitoring of vitals, analgesia, antiemetics if nausea occurs. Antibiotics are not indicated. Recovery occur in majority of patients within 72 hours. In case of severe acute pancreatitis, admit the patient in ICU. Replace fluid and electrolytes. Provide oxygenation. Analgesia. Monitor vitals, intake and output record, arterial blood gases, ABGs. Nasogastric aspiration. Biochemical monitoring, LFTs, RFTs, serum calcium, sugar, TLC, LDH. Antibiotic prophylaxis. If cause of pancreatitis is gallstone or there are signs of cholangitis, then ERCP should be performed to extract the stone from CBD. For systemic support, CVS, inotropic support. Renal failure, dialysis. Respiratory, ventilation. Metabolic, IV calcium, IM magnesium. If sepsis worsens despite these measures, then necrosectomy, debridement of necrotic pancreas, should be considered. That is all for acute pancreatitis. For more videos like these, follow us on YouTube.